Welcome to Reducing Risk, a series of podcasts from medical protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risks looks at key medical legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. This current series focuses on demystifying the Medical Council standards, and today we're looking at the statement on resource constraints. This is a huge topic at the moment, and through our advice line we get calls every day about medical legal risk of working in areas of resource limitation. And because of the breadth of this topic, we've decided to split this subject into 3 podcasts. And so this is actually the 3rd podcast in the series. And today we're going to be looking at the HDC approach to issues that have arisen in situations where services have been unduly stretched. My name's Dr. Lucy Gibbard, and I'm one of the medical legal advisors at MPS, and today we're lucky to be joined by Adam Holloway, a partner at our panel law firm Moot & Coney. Hello, Adam.
Hello, Lucy.
And I'm also very grateful to be joined by my colleague, Dr. Sam King, who's one of the other medical legal advisors at MPS. Hello, Sam.
Hi, Lucy.
So, in our advice line, one of the commonest concerns that clinicians often express is when they're working within an area of resource limitation is, am I going to be held responsible if something goes wrong? We're all aware that even in ideal clinical situations, adverse outcomes occur, and we're probably correct in thinking that when we're stretched, overworked, tired, and don't have time to go back and double check things, the risk of harm to patients or of missing something gets even greater. We always reassure our members that the code states that a provider is not in breach of the code if the provider took reasonable actions in the circumstances to give effect to the rights and comply with the duties of the code. So theoretically, that kind of makes it look like if we're doing the reasonable thing in the circumstances, we shouldn't be in breach of the code. The circumstances in this context includes consumers' clinical circumstances, but also the provider's resource constraints. The problem is, actually, it's up to the provider to prove that the actions they took were reasonable.
That's always the question, isn't it? What is considered reasonable? And I guess it's up to the HDC to make that decision. But really helpfully, the current Commissioner, Morag McDowell, wrote in the New Zealand Medical Journal in April of this year. She wrote an article called "How Does the HDC Code Apply in the Context of Delays?" And in this article, she points out that the significant increase in complaints that the HDC has received over the past few years, and that a number of these are because of delay in care, constrained access to services, and poor communication about those delays. And she has confirmed that the HDC does take into consideration the relevant broader circumstances and context within which the care occurred. But clinicians are still expected to try to minimise those delays, and particularly where care is time dependent and, such as the treatment of cancer.
Yeah, and so that's, the prioritising people on a wait list appropriately, which I always think has got a little bit of the retrospectoscope involved in it, because it's always so easy later to say that patient who had an adverse outcome should have been prioritised higher, but it's actually very hard to prioritise, isn't it?
Everything's easy in hindsight, of course.
Yeah. So I thought for this podcast is a little bit different from the previous 2. We're actually going to go through some of our published HDC cases. So look, anyone can go onto the HDC website and have a look at the cases that they've where the clinicians have been breached mostly, or the providers have been breached. And we're going to have a look at these cases just to see how resource constraints and the way that that's dealt with by the HDC. But before we start, I just wanted to point out a slight problem when we're going through the published HDC cases, because in general, the HDC only publishes cases where the provider's been found in breach of the code, which means that all the cases where the HDC looks at it and the providers are not found in breach, the chances are that's not going to be published on the HDC website. And of the thousands of cases that the HDC has sent every year, it is the minority that are ever found in breach. So actually, there's an awful lot of cases out there that we're not able to look at because there wasn't a breach finding. So we do tend to get a bit of an unrepresentative sample. So I don't want us to come away thinking every resource constraint is breached. It's just that those are the ones that are actually on the HDC website.
That's right, Lucy, and sometimes it's healthy to get a bit of perspective on that, to take a step back and look at the HDC's annual reports that they publish. That's probably the easiest way every year to get a sense of how many complaints come in to the HDC, how many of those are then formally investigated, which itself is a tiny subset, and then how many of the formal investigations end up in breach findings where a formal opinion is concluded and published on the website. And if you look at that from that perspective,
Attrition rate, yeah.
it makes you realise that a lot of what comes in as a complaint to the HDC never gets to the point of these published formal opinions that we'll be thinking about today. And it is a good thing to mention, that we only do ever focus on the worst of the worst.
Yeah. And I think it's about 1 in 20 or even less, isn't it, where complaints that actually go to an investigation. It's really a very small subset,
proportion.
isn't it? And obviously you're not going to be found in breach if they haven't actually formally investigated. So look, the first case we're going to look at concerns delays in the care a woman received regarding her eye treatment, which was 5 or more years ago. And the woman was aged in her 70s and had a history including type 2 diabetes and had got vision deteriorating eye conditions. They've got very long names. I don't think I'll try and say that out loud on the podcast. But one of the issues was that she had age-related macular degeneration. And in May 2017, her injections were changed from Avastin to Lucentis, and that should have been given at monthly intervals and was initially given monthly in June and July 2017. She was actually due for her next injection in August, but there were no available appointments at that time, and so no appointment was offered in August, and there is no evidence that she was actually told that there was going to be a delay in her treatment. She was then not scheduled for an appointment until January 2018, so 5 months later, at which time, when she was seen, it was noted that her central vision had deteriorated and her prognosis had become very poor. They gave her a further injection at the end of January and said that the next one was due in February. But unfortunately, that appointment got delayed as well because of capacity issues, and no appointment was offered then till April. So it happened once and then it happened again. The second time round, a letter was sent informing her of the delay and advising her to seek care at another eye service if she had concerns about her eyesight in the meantime. By the time she was actually seen in April, the ophthalmologist thought that further injections were unlikely to be helpful because she had developed retinal scarring. In this particular case, the DHB, as they then were, was found to be in breach of the code, and they had been found in breach of the code even earlier in 2012 because of delays in their ophthalmology service. And the HDC had raised concerns with the Ministry of Health. So this was a breach finding. The DHB involved told the HDC that the patient appointments in ophthalmology service were booked at that time just in order of who had been waiting the longest. And when clinic slots became available, they put a patient in, but they didn't actually have any form of prioritisation tool in place at that time. They'd been aware of that risk since 2009, so for 8 years, because they just didn't have enough staff for the demand on their service. So quoting this, they said, as this officer stated previously, the existence of systemic pressures does not remove provider accountability in addressing such issues. A key improvement must be made by all districts now and in the future to assess, plan, adapt and respond effectively to demand. So they're saying really you're still accountable even when you haven't got the ability to provide that service. You still have to plan for that. Now, since that case, the DHB has actually implemented many changes, and they introduced an acuity index tool for follow-up appointments, which was a clinical prioritisation tool, and provided a report on those to the HDC. So, Sam, Adam, what do you guys think about that breach finding? They didn't have the resource and the patient wasn't seen, but there weren't appointments to be seen in.
I do wonder whether the breach finding, in part at least, reflected the fact that they'd had a number of complaints before and the HDC had recommended some certain things and nothing had seemingly changed. And you can see that as a result of this complaint, the DHB then instituted some changes, including an acuity index tool for the ophthalmology department. And I wonder whether it perhaps ought to have been instituted prior to that point.
Do you think the HDC actually had a great benefit then to the population here, in that they actually encouraged the DHB to get on and do it?
I actually suspect that it was this complaint that prompted the change, because that's the way it reads here. And so from that perspective, maybe it wasn't necessarily the breach finding, but just perhaps the fact that a complaint was laid with the HDC prompted the DHB to act. So there was a benefit to the community as a result.
I mean, I agree. They seem to have focused on, the HDC in their opinion, is that it's not just that the system was overwhelmed, but there was a lack of effort or systems or thinking around how to respond to that and try and prioritise the people who needed access sooner than others. So if you imagine a scenario where they had been trying extremely hard to set clinical priorities, but were still overwhelmed and unable to provide appointments even to those who they knew needed to be seen, they'd raised this with the government and sent a letter to the people who needed to be seen saying, look, it's important that XYZ happens, but we just don't have capacity to see you. We recommend that you seek care elsewhere. I know that's asking a lot, but they might have avoided a breach. I mean, it's encouraging also that this investigation wasn't into any individual clinicians, and it really was treated as a systems issue from the get-go. There wasn't a focus on a particular person or persons who failed to provide timely care. It was always treated as a problem with the service provider not only not having resource, but also not doing the sorts of things that it could have done to manage that crisis better. And it's always indicative, I think, if you look to the end of the HDC opinions and see what they've changed, if they've instituted a range of really quite meaningful, substantial changes, which they've done, that's an indicator that perhaps it's a fair conclusion, as opposed to sort of token changes like, doing an audit and write a letter of apology. I mean, what they've said here is a bunch of stuff which we as a service have already done to improve the way we manage this issue around lack of capacity. And so it begs the question, why wasn't that done sooner?
And that's what I kind of wonder about from the clinicians who, it was on their risk register from 2009, and this case was 2017. And what the obligation of the SMOs working in that service had, bearing in mind the Medical Council's statement on resource constraints as individuals. Do you think that I'm not trying to apportion blame or anything here, and I'm very glad that the HDC saw it as a systemic issue, which it clearly was, but I'm sure there are departments out there at the moment who are struggling to provide the level of service that may be required. Those SMOs or other clinicians working in those departments, do they have an obligation to act before there's an HDC complaint?
I would hope that hospital departments have enough, or those in leadership of a hospital department have enough capacity to be able to turn their mind to these things. It's not just about fighting the fire, at your door. It's about looking at the whole department and saying, what can we do to improve the service that we provide to the community given the resource constraints? But I think that takes a certain degree of capacity, which, and when you're pressured, perhaps none of them have that capacity.
Maybe time for the meeting to talk about it.
That's right. They don't have enough staff
to
do that. That's right. And so you've got to wonder about that. But in the ideal world, yes, there would be planning in place. There would be proactive strategies put in place.
And I think that's what the resource constraint statement expects, that people will turn their mind to it, and to make sure that the prioritisations are equitable and transparent and, reproducible and fair. So I think there is some expectation that actually clinicians will act before there's an HDC complaint as a department or as a group to actually look at those.
Yeah,
And even if there's not the time available to come up with the solution, at least to have identified the problem and notified it up the chain to say we need help.
We need resources
managing
here to,
this.
Yeah.
I mean, it makes me wonder, and again, perhaps this is a bit too much crystal ball glazing, but it may be that an ophthalmology department is being peopled by a lot of people who are just doing a few tenths. And so you've actually got a sort of a large group of people who are doing a little bit and not like a general med department where you've got a large permanent staff who will find it easier to actually have meetings and solve these sorts of problems because they're not just coming in to do a list or coming in to provide a clinical service. They're there all the time with clinical leads who have enough time outside patient contact to be able to really focus on this sort of issue.
I'm sure that all hospitals have emergency plans in place. If there's an earthquake or something or other, there will be plans in place for a big disaster. But nobody foresaw the pandemic and what the consequences of that would be in terms of staff numbers, even the economy and how that's put the whole population under pressure. So I'm sure that because the pressure came on rapidly, it would be very difficult to forward plan that kind of thing. Yeah.
Yeah, if not impossible. So moving on to another case. This is a case from 2020 about a patient who'd had several admissions to hospital for rectal bleeding and had undergone several investigations, including colonoscopy, CT colonogram, and was later diagnosed with colon cancer. He'd had several admissions with rectal bleeds, and the first time a colonoscopy was requested as he was leaving hospital, he was actually triaged to have a CT colonogram instead. That CT colonogram actually happened and was reported as showing diverticular disease. 2 months later, he was readmitted, and another outpatient colonoscopy was requested, which was booked for 12 weeks later, despite his clinical situation fulfilling the criteria for an urgent colonoscopy. As an explanation, when it came in front of the HDC, the hospital considered that the recent reassuring CT colonogram was probably the reason why the triaging doctor didn't think it was probably urgent. The HDC found that it wasn't unreasonable to have changed the initial request from a colonoscopy to a CTC. Considered that were probably comparative detection rates for lesions greater than a centimetre, including cancers, and it's endorsed as a suitable test by the Ministry of Health and Bowel Cancer New Zealand. Interestingly, although the HDC clinical advisor wasn't critical of that, the ACC expert was. However, the Commissioner's comment was, "I am, of course, aware of the pressure faced by colonoscopy services at a national level due to an increase in demand paired with the workforce shortage and recruitment challenges. Fundamentally, however, it is my view that when investigations are clinically indicated as urgent or semi-urgent, healthcare consumers have the right to expect such investigations to be scheduled sooner than occurred in this case. That such delays are common does not excuse the delay. And I am concerned that if a culture of tolerance of unacceptable delays develops across localities, this will become normalised and patients will be put at risk." End quotes. So clearly in this case, the Commissioner's worried about a culture of tolerance of unacceptable delays. If you're in a hospital where acceptable timeframes for investigation is not being met, what should we do?
It's an extremely difficult question to answer when you've got no resource. Because you've got multiple competing patients for the same limited resource. And I know that for colonoscopies, there will be criteria that must be met. And so patients are graded according to, their symptoms and how serious it might be. But at the same time, even if everyone who was top priority got on that list, there would be still some delays, would be my expectation. So I think I can understand why the HDC say they don't want to normalise this, but the reality is that it is normal practice. It's normal today to have all these delays. So I think it puts the hospital into a very difficult position.
I mean, it is encouraging again that this was the focus of the investigation was the provider, not any individual. And I think this is harsher in many ways than the eye procedure we talked about before, because it seems that this person was appropriately prioritised, that there wasn't a failure to identify acuity. It's just that there wasn't an inability to see this person within the required the time frame. Even the hospital had set for itself. It had said, look, in this clinical situation, people should have their colonoscopy within 2 weeks, but it proved impossible to meet its own target. While that seems a very open and shut case of there being a circumstance that you've tried, but you've run up against the brick wall of what's achievable, I don't see the HDC changing its approach to these sorts of cases. The HDC, and I'm mind reading a bit here, but it must see itself as having a certain role in terms of the architecture we have for regulating healthcare, the provision of healthcare in New Zealand. And for the HDC to say it's not a breach, to use their word, to normalise it in that way, would be quite unhelpful. And I think it's perhaps understandable that a commissioner wouldn't want to be party to that. So while I think an individual clinician can probably think, look, it's unlikely I will ever get breached personally for this sort of situation, people who manage the hospitals are going to have to confront the fact that the HDC is unlikely to change the way it views these sorts of situations. Even individuals still run some risk, but the risk there is around were you enough of an advocate for your patient if you get a referral pushed back? We see that in cases with GPs particularly, where they will still get some scrutiny if they get a needed and justified referral pushed back. There is be an expectation on them to follow that up and say, no, my patient really does need to be seen. So there is still jeopardy in that regard, or a failure to appropriately prioritise. Again, there's got to be risk around being found in breach for just not having the right clinical assessment and putting your patient in the right category. But if in a situation like this, it is simply the resource does not exist to meet the required deadline, then it will be the hospital that is breached, not any individual.
Interestingly, for the GPs involved in these sorts of cases, in some of the cases that I've had, the GPs will say, well, I didn't refer the patient because my experience has shown me that there's no point in referring them because I know they will be rejected. And so they don't refer for that reason, which I think puts the GP in a very difficult position, doesn't it?
And I think many GPs will do that referral because to show that they've tried, knowing that it's going to be rejected. But I think in this situation, it was prioritised urgent. They wanted to do it in 2 weeks. It was 12 weeks. That's a long way outside what they were trying to achieve. Whether they would have been in breach if they had a system at 2 weeks saying, you are due an urgent colonoscopy. We can't meet our timeframes at the moment. This is what you need. they'd communicated better with the patient, would that have made any difference? I'm just thinking, what can a provider do? Or are you saying that actually the HDC are going to breach them, whatever, despite the legislation that says they're going to take circumstances into account, that actually there's nothing they could have done to avoid this breach?
If you look at the previous case, the ophthalmology case, they were critical because the patient wasn't prioritised appropriately. And so there are certain things I think that you can do.
So
But
if they're communicated with this patient at 2 weeks saying, we're now overdue your colonoscopy, we really want to do it, but we just haven't got and then wrote to him every 2 weeks trying to, I don't know.
Would that have prevented the breach? I don't think
Would
so.
it have prevented the breach?
I don't
No?
think so.
But would it have nevertheless been the right thing to do?
Yes.
Probably yes.
Yeah.
And there may be sort of politics at play that aren't visible to me in a hospital writing letters like that, whether it's going to be endorsed by management.
No,
But
they often don't want to actually write those letters, do they?
But a blunt letter to say there is a clinical need for you to have a colonoscopy, you've been graded as semi-urgent. Under our guidelines, that means you need to have your colonoscopy within 2 weeks. But at the moment, we're only giving colonoscopies to urgent and then semi-urgent people on a list, starting from the top. And it's impossible to achieve this for you within 2 weeks. If you've got another way of accessing care, then we recommend you pursue it. A brave letter, perhaps, to write if there are other considerations to take into account. But a fair letter for the consumer.
Yeah.
If there really is no prospect of getting one in public until 3 months have gone.
And I do think the actual another big issue that's around this is, the investigations, waiting for an ultrasound scan or waiting for another kind of scan. There are some places in the country where the ultrasound scan wait lists are hugely long, and that the potential for a patient to be waiting and then turn out to have a significant pathology is significantly high. And often the patients have no idea whether that wait is going to be a week, a month, a year.
I think the other thing too is if they don't communicate with the patient thinks, the hospital thinks it's okay for me to wait 12 weeks. And they won't do anything. Whereas some patients will, borrow money and go have a colonoscopy privately. But I think it's important that patients do know what the situation is so that they can act for themselves if they want to.
So a complete change of tack now with our next case, which is an obstetric case about a young woman who's admitted to hospital with elevated blood pressure in early labour. There was what they call high acuity on the labour ward, which I think means that they were crazy busy. And a clinical emergency occurred during the night, which had a significant impact on staff, such that some of the staff that were on had to go home and the morning staff were asked to come in early. The patient had been in hospital overnight and had rung a bell for attention at 5 a.m, but because of the lack of staff, only an orderly came, because the midwives were all attending to another emergency. The morning staff midwife, who had actually come in early, started a CTG around 6:20 to monitor the fetal heart rate. And that midwife then left the room because there was another patient who was delivering, so she was needed somewhere else. And she thought that the core midwife would be reviewing the patient's CTG trace. But unfortunately, no one looked at it until a third midwife came in at 7:20 who identified an abnormal trace. The woman underwent a caesarean section, but unfortunately the baby was in a poor condition and transferred to SCABU with meconium aspiration syndrome. So the Deputy Commissioner considered this case and thought that the delay between starting the CTG and reviewing the trace was unacceptable. The core midwife had asked the other midwife to set up the CTG, but neither she nor the midwife who had set it up actually went back to look at it in a timely manner because they were both very, very busy. Te Whatu Ora told the HDC that the staff-to-patient ratio on delivery unit was in a negative balance of minus 2.5 hours. So I don't know about negative balance of staff hours, but it sounds like that wasn't a good thing. It also said that the postnatal ward would help out in the delivery unit when necessary, but their staffing was in a negative balance of -7+ hours, so they were unavailable to assist. During that night shift, there were 6 births in 7 hours, not including this patient, 2 emergency caesareans, and an unexpected extreme clinical emergency at around 4:30 a.m. And the clinical emergency staff took staff away from their normal duties, and the trauma of that particular event affected their subsequent care. Te Whatu Ora stated that due to the emotional trauma caused, the staff working that shift had been sent home, and the morning shift had been called to come in early to cover. The HDC found Te Whatu Ora was in breach with regard to the CTG monitoring, and I quote, "I note that the midwife who commenced the CTG was not the midwife who was assigned to care for Mrs. B, and the midwife who commenced the CTG did not assume responsibility for reviewing the trace. My view is that if the entirety of Mrs. B's care had been allocated to a single midwife, then the lines of responsibility may not have been so blurred. It's my opinion that regardless of the stress of the ward, Mrs. B had the right to services at an appropriate standard, and in my view, this standard was not met." So what are the lessons here? Essentially, the ward was in a very resource-constrained situation. You can see people were trying to do other people's job and help out, but it looks like the communication wasn't great, and so that the CTG was put on with no one being very clear about who was going to go back at 15 minutes and read it, because normally you would expect that that trace would be reviewed every 15 to 20 minutes, and it wasn't looked at for an hour. So I don't know, Sam, what do you think about that case? Do you think that was do you think finding Te Whatu Ora in breach in that situation was appropriate?
I think that communication is something that's very basic to healthcare. And I mean, in the ideal situation, of course, you have one clinician who's in charge of a patient, so takes overall responsibility so that patients don't fall through the cracks, as in this case. And the communication doesn't take long. It just means somebody takes responsibility and communicates that. And so I think it was reasonable for Te Whatu Ora to be breached. I'm glad that it wasn't the midwives, because clearly it was a very difficult shift. You know, when staff have to go home because something's been that traumatic that's happened on the ward, I mean, I'm sure that doesn't happen very often. So it sounds like it was an extreme situation. But if there are protocols in place where, everybody knows there is one midwife, who orders the CTG, it's her responsibility or his responsibility to make sure that it's read, in a timely manner, etc., etc., and everyone understands that, there might not have been this gap, if you like. Am I being a bit harsh, Adam?
No, I don't think so. I mean, it's encouraging from the perspective of a lawyer whose job it is often to defend the position of medical practitioners that none of the individuals were found in breach. There were some adverse comments of the midwives, which is the sort of milder option that the commissioner has. But it was treated as a systems level issue, even though the actual behaviours that ended up resulting in the CTG not being read were individual failures of communication. So it's not like the colonoscopy case where there just simply was no one there to do the job. There were people there who did make errors in a way. I don't know if that's the right word, but there were failures to between individuals to say, I will do this, you will do that. Is everyone okay with that plan? But then in terms of where the breach fell, it was on the organisation. So rather than focus on a specific person, they've said, look, collectively this team failed to provide care at an adequate level to the patient. You're always going to have an uphill battle to convince the HDC that there shouldn't be a breach because of a resourcing issue.
But their legislation says that they have to take circumstances into account. Surely this is circumstances.
It absolutely does, but I just from experience and and practical reality, you are always going to have an uphill battle to win that fight, because there will be, in any very complex situation, you analyse it hard enough, you can find a reason why something could have been done better, notwithstanding the resources.
It just seems
And
like a high bar,
it seems
and a kind of a little bit
extremely
unfair,
high.
because
Yeah.
although we say, oh, the organisation was breached, not the individuals, as you say, some of the individuals were criticised who were really working in hugely challenging situation. And, I think that if you were one of those clinicians, I think it would feel...
Oh, absolutely. And I'm not suggesting it's fair, but I am suggesting that's the reality of how it will be looked at. And if you read this opinion, and it got down to the minutiae of the HDC actually doing an analysis of who was in what room when, was there a spare pair of hands that could have been used? And because the onus was on the provider, they failed to show, or could not show, that every single
person was doing a delivery for
was
that
doing
hour,
something more important
for the whole hour.
than checking that CTG. Because a lot of the deliveries that were taking place, the woman had presented with lead providers. There was, in the HTC's view, again, I'm not saying this fair, enough slack in the system that if people had communicated perfectly about that CTG, then it ought to have been possible to check it in a timely way. So, like I say, it's just the reality of the situation we face when we're assisting members with complaints like this. If you're hanging your hat on resource as being your defence, you're fighting an uphill battle.
Which is an interesting... it's reassuring that they, on the whole, in none of these cases are they finding the providers to be the people in breach, as in the individual clinician. So maybe we have to just hang our hat on that and accept that actually, that if the Te Whatu Ora is found in breach, we don't need to feel that means that we have necessarily done a bad job ourselves. Maybe that's how we have to see it. Okay, so moving on to our next case. This is a case, again, from 2020. A woman presented to an emergency department with stomach pain and nausea, and a chest x-ray was taken as part of the clinical investigation. Although the subsequent, and quite distant subsequent, radiology report described a significant abnormal mass in the woman's lung, the ED clinician who ordered the x-ray overlooked the comment, and no further action was taken until the radiology report was noted when the woman attended the emergency department again 3 years later. And as a result of the delay, the opportunity to diagnose the cancer in an early stage was missed. So in this particular situation, the hospital told the HDC that in the case of the ED in Hospital 1, there was a shortage of radiologists in that hospital, and so the radiology had been outsourced to external providers. And so Mrs. A's images had been sent to an external radiology service, and there was an 11-day delay between when the x-ray was sent off site for reporting by a third party and it being received back into the hospital. And that was found to be by the HDC as being unreasonable and increased the possibility of harm to the consumer. So the Commissioner in this case found the DHB's failure to ensure that radiology reporting was completed in an acceptable time frame amounted to a breach of Right 4.1 of the Code. Interestingly, just as an aside, the HDC found that the primary responsibility for taking further action on the radiology report actually lay with the ED clinician who had ordered it, and that clinician was actually found in breach of the code. In his response, he said that he believed his oversight was caused by fatigue, which led him to overlook both the comments in the radiology report about the mass in her chest and also the recommendation for follow-up action. He stated that in 2017, when Mrs. A was admitted to ED, the responsible staff were under instruction from hospital management to clear a backlog of unacknowledged results. And he made time to do this towards the end of his shift when it was likely that fatigue had set in. Now, there is another side here where chest x-ray was copied to the GP, but I think in the context of this podcast, we're probably not going to talk about the fact that the GP did have some shared responsibility there as well. But the reality here is the resource constraint was that there was an 11-day delay in reporting the chest x-ray in the first place. The HDC felt that the healthcare consumers have a right to expect x-rays to be read in fewer days than it occurred in this case, which I love the broadness of that, just fewer days. It doesn't say whether that's 10 or 2. And that such delays are common does not excuse the delay. And I'm concerned, again, about that culture of tolerance of unacceptable delays and that it's being normalised and patients are put at risk. The passage of time between seeing a patient and reviewing a radiology report doesn't support good clinical decision making, and that timely reporting of radiology results is critical to the system working. It's interesting because I think the delay in that report of the plain film was purely a resource issue. So I'm not really sure how the hospital could have fixed that delay. And I'm actually pretty sure that there are some hospitals around at the moment who have significantly longer wait time for some plain film reporting. So, Adam, do you think the HDC took resource limitations into effect when they made this decision to breach the provider?
Well, I think it's a lot like the colonoscopy case. I just don't think we can expect the HDC to, as they may see it, endorse less than best practice or even less than okay practice when it comes to timeframes. If there's a delay that's clinically significant, irrespective of whether there was a way to solve that, I think as a hospital you can probably expect it to get breached if that's had an impact. And I don't imagine that changing in terms of the HDC's position or us being able to persuade them to change their view about that. What's interesting in this case for me is it highlights another aspect of resource constraint, which is probably treated less kindly by the HDC, which is where we have people who are just wrung out. They've worked 2 shifts in a row, or they're extremely tired, stretched, etc. But making a poor, clearly substandard clinical decision, like missing the report of a radiologist that says there's a mass and I recommend that it be followed up. I don't think, in my experience, having raised this on behalf of members over the years, saying accept that was a mistake, but you have to see it in the context of how hard I was working at the time and the human reality that we all make mistakes, and it is inevitable if you put doctors in this position of working this hard and at this sort of tempo that statistically some things will happen that are suboptimal. It's never a successful argument, sadly. The HDC say it's a clinical mistake. We can't again be seen to be saying it's okay to miss something as plain as a recommendation from in a radiology report that a mass needs to be followed up.
They might say in their report, that it's like a mitigating factor.
Yes.
But it never gets the individual clinician off the hook,
No.
sadly. And I guess it's hard to prove, isn't it? It's hard to prove to say, well, actually, I was really tired at the end of that shift. It's not measurable.
It is hard to prove, and I guess it comes back to what do you do in that situation? Because if you are consistently put in a position where you feel like the provision of safe care is being compromised because of your working conditions, then I think the medical council would be expecting you to raise that proactively with whomever's in charge and say, putting it on the record, this is
not safe.
This is not safe.
And so this doctor maybe should, when he was asked to clear this backlog of unacknowledged results, doing it at the end of his shift probably wasn't the wisest time to be doing it. And it's interesting, I was talking to one of my registrars the other day who was saying that she goes through her whole inbox and then she puts the radiology to one side and does it when she's actually a bit pressure, because the radiology is the one that you really have to read the whole thing, because if you just skip to the bottom where it gives you the summary, sometimes there are significant things in that you haven't read. So I thought, what a great registrar. She's got everything that's needed to make a good doctor, because she recognises where the risk sits. And actually reading radiology reports, you've got to be on your game, haven't you?
You do. And we've all probably had a number of cases where something simple was missed, and you can just see how easy it is to miss when you're rushing through your inbox results while you're trying to grab some lunch or something.
So in our last couple of minutes, I just wanted to highlight that issue about communication with consumers about delays. That's right 61C of the code, which gives people the right to information that a reasonable consumer in that consumer's circumstances would expect to receive. And that basically tells us that if there are going to be delays and we're aware of them, the HDC expects that providers will have systems to alert both the consumers and other providers involved in the patient's care about those delays and what timeframes they can expect their care to be provided. And I know that's probably something where everyone is falling down on a lot at the moment. One of the issues there, obviously, is when you've got a huge amount of time pressure already and under-resource, then actually taking the time to communicate to everyone on your waiting list in itself is another thing you haven't got time for. So I don't know if you guys got any feelings on that, but I just find that probably that area is currently not being necessarily addressed very well.
No, and I have in the past had calls from members where they say that they want to write to the patients, but the hospital will not let them, because the hospital management were not keen for patients to know how constrained they were. So these clinicians were put in a very difficult situation. They knew they couldn't see the patients in a timely manner, that patients were going to suffer as a result, and they were not permitted by their employer to communicate that with their patients.
Maybe they need to ring ASNS.
Perhaps they do.
And actually get some advice about how they can actually do that, because look, it's in the Code of Rights there that they need to do that.
Yeah, and it's clear from these cases that that's the expectation of the HDC. And as a patient, you would want to know, wouldn't you? You would expect to be informed if you couldn't be seen in a timely manner.
And I think, if you're able to find the time to write a letter like that, then it will reduce the medico-legal risk for yourself personally, but also for your employer. If they later find themselves the subject of a complaint, being able to point to a clear communication to say, with the best will in the world, you've been triaged appropriately, but we still can't see you in a timely fashion. Here are your other options, is the right thing to do.
Absolutely. So look, in conclusion, I think we can say that the HDC does take into account the resource constraints when making its decisions, but there is definitely still an expectation, if there are limited resources, patients will be appropriately triaged and kept informed of delays that may be expected. And also that actually, if the standard of care is not what the HDC considers is appropriate, even if there are resource constraints causing that, the HDC is likely still to find at least Te Whatu Ora in breach, and occasionally the providers as well. So thank you for listening to this podcast. I hope it's been helpful. And we do hope you'll tune in for our next podcast. We look forward to catching up with you, and if you do like medical protection podcasts, please subscribe and leave a review. If you would like a podcast on a specific topic, or if you've got any questions or queries about this topic, please email us at nzpodcasts@medicalprotection.org. Thanks Sam, thanks Adam, and goodbye everybody.
Thanks Lucy.
Thank you.